Welcome everyone to the respiratory failure floor session. We have an excellent panel of speakers today. I have the pleasure of first introducing Dr. Martin Erner. Dr. Martin Erner is an assistant professor in the Interdepartmental Division of Critical Care Medicine and Department of Anesthesiology and Pain Medicine at the University of Toronto. He graduated from the University of Zurich. He also completed his specialty training in Switzerland, and his research focuses on mechanical ventilation and extracorporeal life support using advanced methods for causal interference on large observational data. Thank you, Dr.
Thank you very much for the introduction, and thank you very much for presenting some of our research work. I know it's the last day of the conference and the last session. As a background, ventilation is provided to millions of patients worldwide per year. And as we know from the seminal publications of Hart-Slotsky and others, mechanical ventilation can also aggravate pre-existing lung injury, although it's a life-saving and supportive therapy. The mortality in acute respiratory failure is still high. If you look at data from the lung-safe investigators published in JAMA, you see that up to 50% of patients with a PF ratio of less than 100 millimeters of mercury die. And we have 4 positive, if you allow me to use the word positive, trials with interventions that improve the survival of our patients in ARDS. This is the ARMA trial limiting high volumes and hospital pressures, the PROSELO trial in prone position, conditional PF ratio. And then, based on meta-analysis, individual patient meta-analysis, higher P, maybe steroids, for sure in COVID, the data from the recovery study, and ECMO therapy, if you believe in the patient reanalysis published in JAMA by Jung Golliger and colleagues. And so, there is an urgent need for additional strategies to address these still high mortality of patients. And one of the additional interventions we could do is maybe limiting driving pressure. And in this paper, Marcelo Amato basically demonstrated that there is a linear association between static driving pressure at baseline and mortality. However, this is baseline data which was associated with an outcome that is after many days of mechanical ventilation. And so it does not really justify an intervention on driving pressure over time. And also the evidence is confined to ARDS patients. There are problems with this mediation analysis because respiratory rate was not included. And in clinical practice, as we know from the lung-safe study, static driving pressure is infrequently measured, especially difficult also in spontaneously breathing patients. Bellani demonstrated that in his anesthesiology paper that 1 in 5, or 10 to 20% of measurements, static measurements, are not reliable. And so we do not really know if we should intervene on driving pressure. In this paper published in Lancet Respiratory Medicine, we were asking whether exposure to higher intensities of mechanical ventilation over time was associated with higher mortality in all mechanically ventilated patients. We used the Toronto Intensive Care Observational Registry with about 13,000 patients to basically measure the association of daily driving pressure, dynamic driving pressure, dynamic mechanical power values, and measure whether those values, the daily values, are associated with ICU mortality up to 30 days. You see, during the first 10 days, sorry for that, during the first 10 days we had most of the events. So many patients actually die or are being discharged from ICU very early on, and these missing values are due to prognosis. So if you think that's just simple missingness, it's informative censoring, and you need methods that are able to account for that in order to measure time-varying association between driving pressure and outcome. We used Bayesian joint models that use a latent subject-specific random effect, and basically a non-observable random effect that explains all interdependencies between driving pressure and alcohol, and thereby also accounts for changing the disease severity over time. I listed here the model equation. You basically compute the marginal association or probability of seeing a certain driving pressure and a certain outcome based on the integral of the probability of seeing driving pressure conditional on this latent subject-specific variable times the instantaneous hazard of dying conditional on this latent subject-specific random effect structure times the probability of surviving up to time point t, and then you multiply this with the probability density of the random effect. And as we know, if we integrate and calculate the area under a probability density function, it's always 1. And if you solve the integral, you will get the marginal effect. And that's what we did here, and we demonstrated that every increase in daily driving pressure and mechanical power on each day of mechanical ventilation or any time point during follow-up was associated with worse outcome. You might now say, okay, it's fine, you used very rigorous methodology to demonstrate that there is an association between driving pressure and outcomes. However, association is not necessarily causation. Only because we demonstrated that these values are associated with outcome is sustained intervention on driving pressure actually changing the patient outcome. And in order to do that, we need to estimate what you see here on the left side. What would have happened had all the patients been treated with a treatment strategy that limits driving pressure versus what would have happened had all the patients received usual care with not limiting the driving pressure or just current practice. And that's something that is not observable, and you cannot just observe that in the data set, you need to analyze your observational data like a randomized controlled trial. And you can do that with the target trial framework. And in this paper, published in Critical Care Medicine, we basically investigated whether sustained intervention on daily dynamic driving pressures reduces mortality compared to usual care in mechanically ventilated patients. We also used the Toronto Intensive Care Observational Registry. Those are the two treatment arms, and our outcome was mortality during mechanical ventilation up to 30 days, because we wanted an outcome with close temporal proximity to the exposure, which makes a causal effect more likely. And we used the parametric G formula, I will explain that a bit later, in order to estimate the per protocol effect on the full adherence. You see, longitudinal data analysis is challenging because you have variables like the severity of respiratory failure, ventilation parameters, and also severity of illness that changes over time. And if I now ventilate Thomas with very high driving pressures, I might cause lung injury, and then I have more inflammation, the PF ratio changes, the elastance changes of the respiratory system, and then the next driving pressure is therefore confounded by current values of ventilator settings and disease severity markers, but these markers might not only act as confounders but also as mediators on the effect on outcome, which basically require specialized methods to analyze it. The parametric G formula is such a method to analyze this data, and it's basically you create parametric regression models for each of your covariates, your time-varying covariates, using actual data. And then you take these models and use them to simulate what would have happened in the study population if everybody had received a specific treatment. And if the distribution of all confounding factors were the same as their distribution in the standard population. It's basically standardization, like we also do in randomized controlled trials. And then when we have the simulated hospital course for this random sample of patients, we predict the outcome for each day of follow-up, and then create or use bootstrap methods to create or estimate confidence intervals. In practical terms, for patient number 1, we simulate the hospital course under usual care. You'll see here age 15, and then the PF ratio of 145, tidal volume of 7, respiratory rate 25, and driving pressure 17. We use this data to simulate what would have happened the next day. And you see that the driving pressure is 17, but it's the usual care strategy. There is no intervention on driving pressure, so we just predict the outcome, and we use these covariates that were simulated for day T1 to simulate T2. And in the intervention treatment arm, however, you see we start with the same covariates, 50, 145 for the PF ratio, 7 for the tidal volume, and we saw that driving pressure is 17, and that's basically non-adherence, or is not allowed in this treatment arm because the driving pressure needs to be limited to equal or below 15. So we adjusted the driving pressure to 15, and then when we use the data from T1 to simulate T2 data on day number 2, now that we change the driving pressure, we need to adjust, or the model needs to adjust the tidal volumes, the respiratory rate. You also see that the PF ratio slightly changed in order to accommodate for this hypothetical intervention. We had 12,865 patients included in the analysis. 2,473 patients had static measurements. Similar as in the OneSafe study, we were not very good in Toronto with measuring static measurements. And you see tidal volumes around 6.7, 6.3. This is in a general population of mechanically ventilated patients, and that is also reflected by the PF ratio. 282 was the median in the entire cohort. And you see positive end expiratory pressures median of 6. This is the result of the primary analysis. Limiting driving pressure to equal, the dynamic driving pressure to equal or below 15 centimeters of water reduced mortality by about 1.9%, risk ratio of 0.9 as compared to usual care. And is nearly 2% reduction in mortality. If you look at the difference, mean difference between dynamic driving pressure between treatment groups, you see that it's on average a difference in 2 centimeters of water in dynamic driving pressure. We did the same analysis for the group with measurements for static driving pressure, and you know it's important to note that most of our patients already have a static driving pressure of equal or less than 15. That is the practice that has changed after the seminal paper of Amato in the New England Journal of Medicine. However, we were still able to observe a dose-dependent effect of limiting static driving pressure on mortality during mechanical ventilation. And it's not surprising, dynamic driving pressure measures static driving pressure and transpulmonary pressure with noise. Then we investigated in secondary analysis what is the ideal time point to limit driving pressure. And the bottom line is, if you see intervention between day 1 to 5, intervention between day 1 to 14, as compared to delayed or late interventions, the earlier you start limiting driving pressure, the better. And ideally, you implement a sustained intervention to limit driving pressure to improve the outcomes of your patient. Then we also did the same analysis you see here on the left side, the dose-dependent effect of limiting driving pressure. We repeated the analysis where we had an intervention on tidal volumes regardless of the driving pressure value. And if you limit tidal volumes regardless of the driving pressure values in a general population of mechanically ventilated patients, there was no effect on mortality, and the same for peak inspiratory pressures, where there was no signal in our sensitivity analysis, in our secondary analysis. In the sensitivity analysis, we tried to see whether there is model misspecification. So we actually tested what would have happened if all the patients had been exposed to driving pressure levels above 50. And we expected that this effect would be harmful, and that's what we found. We also tested control outcomes like whether limiting driving pressure has an influence on the initiation of renal replacement therapy as a control outcome. I know there might be a potential causal link between lung injury and kidney failure. However, we did not find a signal here as expected. We would have been surprised. And the same for a control outcome with a random variable with 50% probability, where for sure no causal effect between the intervention and the outcome was expected. So overall, limiting the daily dynamic driving pressure to levels equal or below 15 in addition to the traditional non-protective mechanical ventilation reduced years adjusted mortality from 18% to by about 1.9%, and sorry, I said it wrong, from 20 to 80.1% by about 1.9%. And we found in secondary analysis similar effects for static driving pressure. Early and sustained interventions are most effective, and these effects were not explained by changes or interventions on tidal volumes or peak inspiratory, regardless of your driving pressure values. They did not reduce mortality, but these findings highlight that we probably, with careful monitoring of daily driving pressures, in addition to tidal volumes per kilogram predicted body weight, may have some room for improvement in our mechanical ventilation practices in order to support our patients. All observational analyses have limitations, potential residual confounding. There are strong parametric modeling assumptions in the G formula. Missing data and multiple imputation may have influenced our results. However, we did diligent and very thorough sensitivity analyses, so it's probably so far the best available evidence on whether we should limit driving pressure during mechanical ventilation or not. And this is how I conclude. Thank you very much.
My pleasure to introduce Dr. Thomas Brano. He's a registered respiratory therapist, educator, and consultant. He's also a lecturer adjunct to the Department of Anesthesia and Division of Critical Care at Master University. He has spoken in over 50 conferences, authorized research, as well as editor of many textbooks and chapters. So, welcome.
Thank you very much. So in 20 minutes, I'll try to describe transpulmonary pressure, a very complex subject, and meaning and usefulness. These are my disclosures, nothing relevant to the presentation. We're going to discuss proper placement, which is a skill. If you think you can leave this lecture and you've never done esophageal pressure and just go into your ICU and do it, you're going to be up for a disappointment. It does require skill and practice. I'll describe various measurements using esophageal pressure, and then discuss some of the clinical applications and research utilizing esophageal pressure measurements. So placement of an esophageal balloon catheter in an adult patient, the balloon portion belongs in the lower third of the esophagus. For most adult patients, this is between 35 and 45 centimeters. It's used as a surrogate of pleural pressure for us to determine transpulmonary pressure, which is the true distending pressure of the lung. And the pleural pressure that's estimated with esophageal pressure is used to calculate transpulmonary pressure. If you have it integrated on your ventilator, it's very nice. You can look at directly measuring transpulmonary pressure very easily. Here we have a transpulmonary pressure waveform. The esophageal waveform can also be brought up on the screen, but in real time you get this idea of the dynamic stress on the lungs. There are also available bedside monitors that if you don't have the integration, you have the pressure flow transducer and a catheter and a standalone device. And if you want to just measure pressures, you can use an ICU monitor with a catheter and a transducer, but it does require converting millimeters of mercury to centimeters of water for doing calculations related to the ventilator, but you lose the ability to monitor things such as asynchrony, which I'll talk about later. In terms of proper positioning, once you've inserted the catheter, you do have to confirm that the catheter is in the same thoracic space as the lungs. So if you think about the catheter sitting within your thoracic space, if you were to occlude the airway and press on a passive patient's chest, then the change in pressure measured by the esophageal pressure should be the identical pressure change measured in the ventilator circuit on the ventilator. Now we do have an acceptance when we divide the two changes, usually within 20%. Some people are more strict and they'll use 10%, but overall it's been 20% has been the acceptable value in most studies. And then if a patient is breathing spontaneously, you don't need to include you do need to include the airway, but you don't need to push on the chest at all. You allow the patient to make a spontaneous effort, and the change in pressure should be similar to the change in esophageal pressure. And again, you can calculate the two values so you can confirm proper placement. Once you have the catheter in place, it's a matter of doing an inspiratory pause in passive patients if you want to calculate transpulmonary pressure. You do an inspiratory pause followed by an expiratory pause. And so you have an end expiratory pause in total PEEP, we have end expiratory esophageal pressure, and the subtracting, just airway minus esophageal, gives us the end expiratory transpulmonary pressure. And then over here we have plateau pressure, we have the esophageal plateau pressure, giving us the inspiratory directly measured transpulmonary pressure. But using these values, like resistive dynamic pressure, respiratory system dynamic pressure, esophageal driving pressure, and looking at the transpulmonary driving pressure, you can calculate many other useful information. So using the directly measured values, you have airway pressure minus esophageal pressure. This is done during an inspiratory or expiratory pause. This is useful for setting PEEP and has been used in clinical trials for limiting plateau pressure, but I'll talk about some of those limitations. The elastance-derived method uses the changes in transpulmonary or chest wall compliance to calculate the elastance. It's essentially the percentage of the amount of pressure you're applying to the lung, how much that percent is actually being felt by the lung. So you take airway pressure and you multiply it by this elastance ratio, and it tells you how much the pressure is being applied or distended in the lung. And this can be utilized for limiting plateau pressure. I'm sure everyone can easily just calculate this, no problem at the bedside, but if not, if you don't want to use a large piece of paper, I have designed an online calculator. It's free to use, you do not need to create an account. That's just if you want to save some information. You can put a non-patient identifier. But essentially with the calculator, you can change, doing the push on the chest as I described. You can choose if it's centimeters of water, or if you're using an ICU monitor, you can use millimeters of mercury. We can see the ratio is acceptable. At end expiratory pause, I have 12 centimeters of water in the esophagus. An inspiratory pause, 16. My PEEP total is 14, my plateau is 28, the tidal line is this. And it gives me all the values that I require. There's respiratory system driving pressure, respiratory system compliance, chest wall compliance, directly measured transpulmonary pressure, both expiratory and inspiratory, the elastance ratio, and when multiplied by plateau pressure, it gives me the elastance-derived transpulmonary pressure. So a lot of very useful information from a very simple calculator. In terms of how we use this clinically, that's a whole other subject. So we can use it to separate respiratory system mechanics into lung and chest wall components, and if that's the purpose of your research or your interest at the bedside, this is the best way to do it. We can use it to set PEEP, and I'll talk about some of the studies that utilize that, as well as monitor the potential for lung injury, as I just described, looking at the elastance ratio, and we can use it to monitor patient effort. Now, I'm about to show you a short video describing the concept of setting PEEP according to your esophageal pressure to give you a transpulmonary pressure at end exhalation of 0, meaning at end exhalation the pressure in the lung is equal to the pressure outside the lung, and therefore you don't have collapse. Now the video is a test lung. It's simulating one big alveoli, which I understand the lung is not like this. ARDS is very heterogeneous, but it gives the concept. So here we have a ventilator with a PEEP of 6 in a sealed water bottle, and outside I have a CPAP machine simulating pleural pressure of 6 centimeters of water. So the ventilator PEEP is 6, the pleural pressure is 6, the lung is open, but look what happens when I increase the simulated pleural pressure to 12 centimeters of water. I now have a negative end expiratory transpulmonary of -6. How do I fix this? I increase the PEEP to 12 so that the pressure inside the lung matches the pressure outside the lung, and you'll see the test lung inflates. Again, this is simulation, proof of concept. It's not that magical at the bedside for many patients, but I hope you understand visually what I'm saying. Now the inspiratory transpulmonary pressure, why this is very important, is this work from Luciano Gagnoni, may he rest in peace, from 2004, describing how the impact of the chest wall, how it can really differentiate your patients. When you apply 30 centimeters of water of pressure to a patient, let's say your plateau is 30, a patient with a normal or soft chest wall, they may feel 80% of that pressure. This is, I'm just rounding the number here, but 25 centimeters of water of distending pressure is what they might feel. And in this example, a patient with a stiff chest wall or intra-abdominal compartment syndrome, they may only feel 50% of that pressure, so you could safely increase pressure in a patient like this versus this patient who would want to maintain that limited pressure. However, we do have some issues with transpulmonary pressure measurements using the esophageal balloon catheter, and this has to do with the placement and the positioning of the catheter and where it sits within the lungs. So as you can see, the esophageal pressure sits here, which it mostly reflects the lower portion of the lungs, and this elegant study by Takeshi Yoshida and colleagues published in 2018 in the Blue Journal, they actually placed pressure transducers in the ventral and dorsal regions of teal cadavers, which are cadavers that retain elastic properties. And they found that if you do an end expiratory transpulmonary pressure measurement and you increase PEEP, this is where the transpulmonary pressure, this is the esophageal pressure, this is the end expiratory transpulmonary pressure measured here, and this is the end expiratory, this is the dependent center, and this is the non-dependent sensor. So you can see there is variability in what you're actually, when you set your PEEP, how it will be impacting the entire lung. So it really is an estimate. Having said that, the reason why we still look at this as the best way to use esophageal pressure is because you are reflecting the regions of the lungs that typically have problems with staying inflated. However, when they looked at the inspiratory transpulmonary pressure, you can see that it's representing, this is the esophageal pressure, and this is the ventral region here. This is the region at most risk of ventilator-induced lung injury. And when you look at the inspiratory pressure here, it is greatly underestimated by using the directly measured value, but when you calculate the elastostride method, it actually reflects this region quite well, and therefore would likely be a better target if you were to use it during inspiration. The largest trial we have to date using esophageal pressure to guide PEEP and limit plateau is the EPVENT-2 trial. There was also an EPVENT-1 trial, but for time I'm just going to discuss this one. They used an end expiratory transpulmonary pressure target of 0 and up to 6 centimeters of water. Similar to a PEEP FiO2 table, they had an end expiratory transpulmonary FiO2 table, and they limited inspiratory transpulmonary pressure to 20 centimeters of water. So your patient could have a plateau of 50, provided the inspiratory transpulmonary pressure was 20 or less. There was no difference in any patient outcome compared to a high PEEP FiO2 table. There was significantly more rescue strategies in the control group, but not having as many rescue strategies doesn't add up to improved outcomes. So the potential issues that I had when I read the study was I've seen patients clinically, and in fact I enrolled patients into the study when I worked at Hamilton at St. Joseph's Healthcare, and some patients, when we would increase the end expiratory transpulmonary pressure up to 4, 5, and 6 based on their FiO2 requirements, some patients, even though they had an inspiratory transpulmonary pressure of 20 or less, I really felt like they were being overdistended. Their response was not positive. And so this was one concern I had. Even while we were doing the trial, I thought to myself, maybe these patients are not recruitable. We weren't testing recruitment potential, and maybe trying to increase further just caused worse overdistension. And remember, we're underestimating the healthy parts of the lung by using this as a target. So this directly measured may underestimate regional strain and of the non-dependent regions. Now they've done some post-hoc analyses with this work, which they found that when they looked at patients that had their end expiratory transpulmonary pressure within plus or minus 2, they were able to distinguish or separate survival probability. Again, this is a post-hoc analysis, but it demonstrates that perhaps the excessive end expiratory transpulmonary pressure or patients that had severely negative end expiratory transpulmonary pressure in the control group, maybe the benefit really is when you get very close to 0, but then we don't over-target it. And another post-analysis from their data looking at transpulmonary driving pressure, if you look, you can see that 10 centimeters of water of transpulmonary driving pressure kind of separated survivors and non-survivors. And if you think about their protocol, if I just go back quickly, their protocol would allow you to set an end expiratory transpulmonary pressure of 0 and allow up to 20. And now so that would be a driving transpulmonary pressure of 20 centimeters of water. And they found with their own data that a driving pressure of 10 distinguishes survival and not. So this, again, more thought-provoking information. Further, we have this nice paper by Lieutenant and colleagues published in 2022 that compared all of these values to see, are they actually useful in terms of assessing the risk of ventilator harm. They looked at transpulmonary driving pressure. They did find that there was did find a separation around 12 centimeters of water of transpulmonary driving pressure. The airway driving pressure, however, they used a change of 12. And you can see that it's actually a better predictor of separating out survival versus non-survival. And when they looked at the elastance drive transpulmonary pressure using a limit that's been utilized routinely in clinical practice of 24, again, they found that airway driving pressure was just as good or better at predicting survival. So currently, the EPVent 1 and 2 group are now performing a study, and they're choosing not to call it EPVent 3, maybe just to try to change people's mindset, but they're using it's called the PREVENT-BILLY study. And they're using esophageal manometry to titrate PEEP to a transpulmonary pressure of 0. They're not using a table anymore where they're going to go higher if the FiO2 is higher. And instead of using inspiratory transpulmonary pressure, they're just using driving pressure. Now they're choosing 12 centimeters of water or less. This could be due to the fact that they're measuring total PEEP as the driving pressure. The model paper used set PEEP, so perhaps they're accounting for some of their own data. I'm guessing they chose 12 based on their own data rather than trying to go against the model paper. And finally, when you have passive patients and they begin to wake up, when I worked clinically in Hamilton with this, I would always be frustrated when I show up to the ICU and I find out that the respiratory therapist had taken the catheter out when the patient began spontaneously breathing, even when we had it integrated on the ventilator, because they thought that it was useless now, so they would take it out. And I'm like, no, this is actually a very useful tool, because in passive ventilation, you see esophageal pressure goes up with every breath delivered by the ventilator. This is essentially your chest wall pressure. And when they start breathing, you can then assess the interaction between patient effort and the ventilator breaths, which of course is great for asynchrony detection. If you are unable to properly identify reverse triggering at the bedside, having an esophageal pressure tracing, you can clearly see that the breath begins by a positive deflection of esophageal pressure, which happens when the ventilator delivers a positive breath, followed by a patient effort immediately after, which explains the other discrepancies you see in the expiratory flow. Finally, using esophageal pressure dynamically at the bedside, you have these swings in esophageal pressure. If it's integrated on your ventilator, you actually have the dynamic transpulmonary pressure right there on your ventilator without doing any fancy measurements. This is very useful. Now, having said that, as useful as it is, we do have measurements like the PIOC maneuver, which accurately detects dynamic driving pressure, or dynamic transpulmonary pressure, greater than 15, which you're starting to worry once we get higher and higher. So you know that injurious levels will be accurately detected with this maneuver. And you can also calculate PMUS using esophageal pressure. Now the PIOC maneuver, I'll just go back quickly, you can also use it to detect PMUS. But if you have an esophageal catheter, you can also do this quite accurately. And in fact, this is what they compared it to. This is the gold standard. So if you know the patient's delta PES during passive ventilation, essentially the chest wall pressure, just through mathematical equation, it ends up being delta PES, similar to driving pressure. When you divide tidal volume by respiratory system compliance, you're basically getting plateau minus PEEP. It's essentially this change here is your chest wall pressure. When you multiply it by the swing during spontaneous breathing, you have a PMUS value. Now, if you didn't document this during passive ventilation, you can use an estimated equation for estimating chest wall pressure and still get the same values with good accuracy. Now, the patient population that I would suggest, everyone who's not sure if they should integrate esophageal pressure manometry into clinical practice, if you have a large population of obese patients, you really should consider implementing an esophageal balloon strategy. These patients not only have very challenging course of action in acute phase of their lung injury, but also in the weaning phase. They just have a disadvantage with their FRC based on their weight. And you can more easily target acceptable or standard PEEP levels for these patients if you understand the complexity. Now, you could, of course, just increase your PEEP, but show of hands, how many people are comfortable increasing PEEP above 20 centimeters of water in an acutely ill patient? The people who use esophageal pressure do. So I have seen PEEPs as high as 32 centimeters of water, and patients were sent to the wards 10 days later. So this is extremely important, and when you have not only obese patients, but intra-abdominal hypertension, it's a very, very useful tool. And this was a nice study published by the group led by Bob Kazmarek, another person, may he rest in peace. They looked at a sort of a retrospective analysis of how patients were managed standard. They basically assessed patients with obesity, and then after they implemented this lung rescue team, now of course this is retrospective analysis, practice may have changed over the time, But this huge drop in how these patients' outcomes change really indicates that perhaps this is a very good target audience for using esophageal pressure to guide PEEP, which is what they used. Essentially, they had standard care, which was the ARDSNet table, and then they used best PEEP titration or decremental PEEP trial using other methods, but really they were measuring a lot of transpulmonary pressure in these patients. So in summary, esophageal balloon pressure requires proper technique and skill, and if you have obese patients, I highly recommend learning this skill. It does allow partitioning of the lung and the chest wall mechanics at the bedside, which is very interesting, but we're not sure how that impacts clinical outcomes at this time. It can provide valuable information regarding PEEP requirements, provide insight into patient-ventilator interactions with asynchrony, and it's an essential tool, in my personal opinion, monitoring patients with obesity and intra-abdominal compartment syndrome. And ongoing studies, of course, are required to determine whether the routine use of esophageal pressure measurements in clinical practice will lead to improved outcomes. And I encourage you to check out the blog, cumv.blog, and of course, the online calculator.
Thank you very much for that talk. I'd like to welcome on stage Dr. Lorenzo Del Sorbo. Dr. Del Sorbo is an intensive care attending at Toronto General Hospital and is an associate professor at the University of Toronto. He trained in internal medicine at the University of Torino, so from Torino to Toronto. And Lorenzo's main academic interests focus on the application of innovative strategies to prevent the injury induced by invasive mechanical ventilation, including extracorporeal life support strategies in patients with acute respiratory failure and lung transplantation. Thank you.
Thank you very much for the kind introduction. Yes, indeed, I was the first fellow of the U of T's, University of Turin, University of Toronto, and I want to echo also the gratitude to the organizer and to Dr. Alvarez in particular for this fantastic, outstanding conference. So let me talk in the next few minutes about how we monitor the use of high-flow nasal cannula. I'm very grateful that my talk comes after one of Tom Pirano, because many concepts that I'll show, maybe that I'll show are easier to understand after his talk on esophageal manometry, and the conclusion are exactly the same. More study will be needed. So I don't have conflict. Okay, high-flow nasal cannula, so we know is a device that provides flow to the patient up to 6 liters per minute, different from the usual low flow, below 10 to 15 liters per minute with venturi mask or nasoprongs. It delivers warm, so heated and humidified gas. So the high flow is a key factor. Most of the patients with respiratory distress have increased peak inspiratory flow definitely greater than 50 liters per minute. So providing flow up to 60 liters per minute matches their inspiratory flow, and that has two advantages. One is more comfort, and second, we're more sure about the FiO2 provided to these patients. So you can imagine if a patient has 60 liters of peak inspiratory flow and we provide 15 liters of oxygen, 100%, the real resulting FiO2 is way less, because a bunch of liters per minute of inspiratory flow are entrained by atmospheric air and not by the oxygen delivery device. There are data showing that the heat and humidified gas really improves the mucociliary clearance, and especially in patients with bronchiectasis, for example, this is very useful to maintain airway clearance and facilitate expectoration. And we all know that there are some data showing that the turbulent flow in the upper airway may provide the patient with some end expiratory positive pressure, which may result in a higher end expiratory lung volume. And this turbulent flow is effective not only in providing maybe some PEEP, especially patients that breathe with the mouth closed, and so the turbulent flow really exerts some increased pressure in the upper airway, but facilitate this turbulent flow CO2 clearance, so decreasing or eliminating the upper airway from the anatomical that space. So all these effects are interplaying, and this is a nice editorial by Johan Noliger and ours last year, published a few years ago, where all the resultant from the effect that I showed are indicated. And so let's see in clinical practice some data. So this is the fluoride trial, one of the largest, and maybe the first large multi-center randomized trial that included randomized patients with hypoxemic respiratory failure, so PF ratio less than 300 while on at least O2 of 10 liters per minute for at least 15 minutes, excluding patients with hypercapnic respiratory failure or chronic respiratory failure, and some respiratory distress as indicated by a respiratory rate of at least 25. So these patients with acute hypoxemic respiratory failure were randomized to receive either Optiflow, standard oxygen, or non-invasive ventilation. The primary outcome is the proportion of patients who require intubation, and I indicate here on the right-hand side the pre-specified criteria for endotracheal intubation, because these are really the clinical parameters that we need to monitor carefully and thoroughly in these patients. So hemodynamic instability, so the new requirement of vasopressors or blood pressure that decreases despite fluid bolus, deterioration of neurological status, and they indicated on GCS of 12 their threshold, and signs of persisting or worsening respiratory failure, defined as increased respiratory rate over 40, lack of improvement in the work of breathing, and development copious amount of secretion indicating some pulmonary edema ongoing, respiratory acidosis, and hypoxemia indicated by an oxygen saturation less than 90 for more than 5 minutes. So these are very, very important clinical parameters that we need to monitor. The result, sort of surprising. So the overall data didn't show any difference according to the device that was used to support this patient. You can clearly see in the overall population and on the top that high flow maybe perform better than non-invasive ventilation and oxygen, standard oxygen. It was very surprising that non-invasive ventilation performed so badly, and this may be due to a different dose, because it's way less tolerated than non-invasive ventilation compared to Optiflow, and maybe to some potential ventilator-induced or ventilation-induced lung injury in patients undergoing non-invasive ventilation. Definitely, there's subgroup analysis, which is hypothesis generating, but a clear signal in favoring high flow nasal oxygen. So there were many more randomized trials comparing the effect of Optiflow versus conventional oxygen treatment, and these trials were summarizing these nice guidelines generated by the work in particular of Brand Rochworth and from Hamilton, and there's no, so 9 trials, some with large potential for bias, but overall an effect in favor of the use of Optiflow in patients with acute hypoxemic respiratory failure. So they end up, for example, patient with acute hypoxemic respiratory failure, giving a recommendation with strong recommendation, although moderate certainty of evidence. They also noticed that in this trial, the adverse events directly related to the use of high flow were uncommon, and they noticed in the literature, especially from data coming from observational trial, that may be a signal that the use of Optiflow may delay intubation. This is not confirmed in the secondary analysis of the Florali trial or other randomized clinical trial. It's something to keep in mind. And there's some report of nasal bleeding that wasn't very concerning. So, do we need to monitor these patients? And how do we monitor these patients, especially if we are really concerned of delaying potential intubation, which may be associated with higher mortality? Okay, so one nice paper was paper indicating the ROX index as the potential variable to follow and decide if the patient requires more invasive ventilation or not. This is a 2-year multi-center prospective observational course study, including patients only with pneumonia treated with iFlow. The iFlow was initiated at 30 liters per minute with FiO2 100% and then titrated FiO2 to oxygen saturation of 92, and the flow rate was adjusted and reduced as much as tolerated. Again, I recorded here the criteria, the predefined criteria for intubation in decrease LOC, GCS of 12, cardiac arrest or arrhythmias, severe and instability, and then increased work of breathing, hypoxemia, and inability to clear secretions. So these are the clinical characteristics of the patient involved in the trial. And then just to remind everyone, the ROX index is the ratio between the oxygen saturation divided by FiO2 and all divided by respiratory rate. So this is a complex, lots of numbers here showing, of course, they follow the patient in different hours prior to the use of iFlow at 2 hours, 6 hours, 12 hours, 18 hours, and 24 hours, showing how each parameters behave in their correlation with the outcome, and definitely the ROX index was the one with better correlation. However, the specificity and sensitivity wasn't, especially the specificity as indicated on the panel on the right-hand side, wasn't the greatest. They indicated at the bottom there that the ROX index less than 2.85 at 2 hours, less than 3.47 at 6 hours, or less than 3.85 at 12 hours were predictors of OptiFlow failure. As I said, the specificity wasn't the greatest one. So what else can we monitor then for these patients? So I'll present some data of 2 physiologic studies by the group of Pesenti, first author Tommaso Mauri. They included 15 ICU patients with acute hypoxemic respiratory failure, non-intubated, and they designed a crossover physiologic study where patients were treated randomly, initially with OptiFlow or oxygen. Each phase was 20 minutes, and they measure arterial blood gases and then inspiratory effort and work of breathing by esophageal pressure swing, and they measure the pressure time product. And then they use EIT, electrical impedance tomography, to understand and record the distribution of ventilation. So you can see the data here, the results here. So the patient on iFlow had significantly less esophageal pressure swing, more favorable pressure time product, and the mini ventilation decrease and oxygenation got better. These are the more granular data on the left-hand side. Also, the ventilation on EIT was significantly more homogeneously distributed using OptiFlow versus oxygen, and the lung volume and expiration was significantly higher. So it seems to have a huge physiologic effect. It's suggesting that maybe we should measure work of breathing more carefully with esophageal pressure swing as a monitor tool to understand if the patient is really responding to our treatment. They did another crossover physiologic study in 17 ICU patients, similar inclusion criteria. But this time, they used all the patients were treated with the iFlow nasal cannula, but there were 3 phases with different flow, 45 and 60 liters per minute, randomly applied, each one for 20 minutes, and they measured the same variables. So they really showed that by increasing the flow, maintaining the same FiO2, the work of breathing as measured by the pressure time product decreased, the mean ventilation significantly decreased, and again, the end expiratory lung volume by EIT was increased, and oxygenation got better. So two words on this specific tool. One is electrical impedance tomography, so it's a radiation-free, real-time tool, recording tool, relying on the very small electrical current delivered to the patient through a belt that we strap around the chest of the patient. You can see here the picture of the electrode. We can monitor the impedance to the electricity, which is proportional to the change in aeration. As you can see here, during inspiration, the image becomes bluer, indicating air is going into the patient, and when it becomes darker, the air is expired. So we can really measure how the ventilation is distributed, and that's how they apply. Maybe clinically usable. I don't know if we can leave the belt around the patient for many hours, but somewhat still complicated. And this is the way we measure pressure time product with esophageal manometry. We need to insert the esophageal catheter and check the position, and then we identify the inspiratory time and measure the area under the curve, which is very accurately indicating work of breathing. Really, maybe more a research tool rather than a clinical tool, but good news, the group in Modena, led by Roberto Tonelli, developed this new device, a custom-made nasal pressure monitoring system that is placed in the same nostrils in the esophageal tube. Doesn't require esophageal tube, but they use that to understand if they were able to measure work of breathing by this simple device that was measuring the change, the amplitude change in the nostril. And they show, as you can see, that there may be some delay compared to the esophageal manometry measurement, but the overall data are really correlating very well. So stay tuned, because this may be a very good tool, relatively non-invasive, to monitor work of breathing in these patients. So the summary, everyone likes the summary at the end of the talk. In particular, I like that, so I know what to think when I leave. High flow nasal oxygen is strongly recommended in patients with acute hypoxemic respiratory failure compared to conventional oxygen treatment. OptiFlow causes very rare adverse events, so the safety profile is very high. OptiFlow exerts its clinical effect through different various potential physiological mechanisms. Clinical monitoring is good. You can do it with the ROX index, but the specificity is very low, so monitor the patient at the bedside according to the criteria for intubation, and stay tuned for more study coming up to understand if work of breathing will be part of our decision-making process in the future to treat and to improve outcomes in this patient. Thank you very much for your time.
Certainly last but not least, Dr. Walid Al-Hazani is the director of the Health Research Center, the General Administration of Health Service of the Ministry of Defense in Saudi Arabia. And he's one of the most renowned critical care physicians and researchers in the field. So, welcome.
Thank you for the humbling introduction. Assalamu alaikum. It's a great pleasure to be here today. And as they say the best for last. These guys are better. Fine. Okay. These are my disclosures. They're mostly academic. I have no other financial, direct or indirect conflict of interest related to this topic. Hopefully by the end of today, it will be heavily evidence-based talk. So slightly change from pure or mostly interesting physiology and mechanics. It will be probably a very heavy ABM, so bear with me. So I was asked to speak about the use of awake proning in non-COVID patients. But before we start, I want to ask you guys, did you actually use awake proning during the COVID era? Yeah, almost everybody in the room did that. That's great. Okay, how many have used it in hypoxemic patients without COVID? A handful of people, which is expected. If you remember, the pathophysiology of COVID was very complex, involving interaction between vascular problems, changes in lung mechanics, DQ mismatch, third spacing with hyperinflammatory state. All of this and the concern about self-induced lung injury and going into this vicious cycle with patient hungry for air despite normal oxygenation have led people to worry and attempt intubating patients very, very early on during the COVID pandemic. In fact, people were like saying, just intubate them. I've seen practices where they intubated patients on 5 liters of oxygen. And I think people were worried to get infected, but they didn't account for the lack and shortage of ventilators that will happen, and also harming the patients by putting them on the ventilator. At that time, I think the hypothesis was mainly from indirect evidence on proning patients who are sedated, often paralyzed, mechanically ventilated, in which in the supine position there is inhomogeneous distribution of ventilation and differential strain changes throughout the lung zones. And when you prone those patients, hopefully you improve their ventilation and oxygenation by recruiting areas of the lung that were not accessible in the supine position. And I still remember, I was hoping that Zainab will be here. I think she had to go and catch her flight. But when Zainab Dhalib was doing her fellowship, when I used to work at McMaster, she did her master's with me. We were on rounds, and I believe she saw a tweet. I looked for that tweet to show you, but I couldn't find it. It's pretty old now, where somebody had proned a patient while they're awake, and there was a huge improvement in oxygenation. All of a sudden, everybody on social media was using it. And Zainab said, let's do an RCT. I'm like, that's a brilliant idea, let's do it. So this have led to the COVID-prone research program that consisted of an international survey of practitioners. We did a systematic review. Obviously, at that time, there were no studies on awake patients, but we collaborated with a group in Calgary who were also interested in the topic, and we applied for a CHR grant, and we got funded for 2 trials, COVID-prone and Corona. Corona was supposed to address or focus on patients who are not for intubation, and the aim is to try to prevent death, but without looking at ventilation, intubation outcomes. However, in COVID-prone, we had a slightly different question. It was an international study. Kuwait have participated in the study, Dr. Abdurrahman Al-Faris, also Dr. Yasin Arabi, who's I think also is back in Saudi. Tom also was on the steering committee of this trial as well. So the research question we ask is, does awake prone positioning reduce the risk of endotracheal intubation in awake adults with hypoxemia from COVID-19? We were lucky to get multiple international sources of funding to fund the trial. It was probably one of the hardest trials that I participated in, not only because of the pandemic, but as you will see, the intervention itself is very difficult to implement in usual practice, let alone in a pandemic. We were lucky to have 21 sites participating from Canada, US, Kuwait, and Saudi Arabia. Our inclusion criteria focused on adults with suspected or confirmed COVID-19. They have to have hypoxemia requiring at least 40% oxygen, and they have evidence of infiltrates on X-ray, and they have to be in an acute care setting or in an ICU to be included. The usual exclusion criteria, so those with contraindications or concerns of being prone positioned for their safety, or those who have been proning already in the trial. Believe it or not, even during the lack of RCTs, we had difficulty recruiting sites. Some sites said there is no equipoise, which also it's humbling, because this is one of the examples where, yeah, the hypothesis panned out, but also you remember the story of hydroxychloroquine, where people stopped using it for what it should be used for and started, pushing it in patients just because of physiological and basic science evidence. And the evidence turns out to be harmful, in fact, not only not beneficial. So anyways, we pushed for this trial. Our intervention was aimed to prone patients for 8 to 10 hours daily. We give them multiple breaks in supine position. And the intervention would continue until there is a relative improvement of oxygenation by 40% from baseline. It was completely arbitrary, as Tom may remember. Or if the patient obviously is intubated, or if they get discharged, or if they die. The usual care included, your usual care without allowing proning. And after finishing recruitment, they were a sick cohort of patients. We randomized close to 400 patients, many of which, more than 50%, had significant hypoxemia, as you can see. Significant oxygen requirement. The median was about 70%. Many of them were on high-flow nasal oxygen, as you can see, and even few were receiving an IV during enrollment. Lesson 1, we were not able to achieve that 8 to 10 hours of proning, but we were able to achieve a median of around 5 hours, up to 6 hours if you exclude patients who didn't prone at all. And the median duration of, or days of proning was around 3 days. Despite that, there was a lot of contamination in the control group where patients were actually prone due to concern from physicians. Patients who did any proning hours were 90% of the intervention group, but also close to 20% in the control group did some proning. When we look at the adherence, and again, this is important, and I'm mentioning it because it really reflects in clinical practice. Adherence, compared to other clinical trials, was better than most of them, but still not what we hoped for. It ranged anywhere between 50 to 80%. Obviously, as the patient improved, time goes on, adherence is not the greatest. And the main complaint was mostly discomfort, pain, and honestly, lack of encouragement. Staff are really scared to go into the room during the pandemic. So this is what we found. As you can see in the Kaplan-Meier curve, there is separation between both groups. However, the hazard ratio, though suggested close to 20% relative risk reduction in death, the confidence interval was imprecise. Similar when you look at mortality, although there is separation and the actual numbers look different, the point estimate and the confidence interval still were not significant. Similarly, for other secondary outcomes, including mechanical ventilation-free days, ICU-free days, they all were, I hate this word trend, but they were in the trend of favoring the awake-prone positioning. When you look at the subgroup analyses, what caught our attention at that time, and I'll show you the value of this in the next few slides, that patients who are less sick, they're still pretty sick, but with SF ratios 150 or above, had a significant benefit compared to those who were more sick, and those who were on high-flow nasal cannula when they got proned, compared to those who were on NIV, they got worse after proning. Although, mind you, that we used a very aggressive adjustment for multiple testing. So although the actual subgroup analysis P interaction was significant, but when you adjust for multiple testing, you lose that significant. You probably all are familiar with the meta trial. This was the first time that I hear this terminology. When you look closely at the study, it was 6 trials from 6 different countries analyzed together. They had different protocols for the intervention. So they didn't have the same inclusion criteria or the same protocolization of awake proning, yet they analyzed them as one trial. So to me, it's a prospective meta-analysis rather than a meta-trial. However, the results were interesting. I think the results were driven by the Mexican arm of the study. They also had significant issues with adherence to intervention. Nevertheless, when all the studies put together, there was a significant reduction in the risk of endotracheal intubation, about 25% relative risk reduction. They didn't find any mortality benefit from proning patients prior to getting intubated, but they also found similar challenges in adhering to proning hours, and also the benefit seems to be outweighs treatment failure in prolonged hours of intubation. And then subsequently, multiple smaller studies have been published. We published a meta-analysis of, I believe, 17 RCTs, at that time just short of 3,000 patients in the BMJ. And again, similar to what we found in the clinical trials, there is a reduction in the risk of endotracheal intubation. And this translates into 17% relative risk reduction, or if you look at it in terms of absolute terms, 55 fewer intubations for every 1,000 patients that you prone. Again, we didn't see a significant reduction in mortality. We also pushed it a little further, and we used Bayesian meta-analyses using different priors, including non-informative priors, enthusiastic, skeptical priors, and again, the results were robust, both for the intubation outcomes and for the mortality outcome as well. So if you look at the intubation outcome, the probability of harm was essentially zero. When you look at mortality, was not zero, but pretty close to zero. So at least a conclusion that awake proning is not harmful. The golden question is, if you prone those patients, how long you should prone them for? Again, we did a subgroup analysis by hours of proning, and we chose 5 hours as the median proning hours across the studies. And although the numbers are slightly in favor of longer hours of proning, the P of interaction was not significant between both groups. Even in studies or in patients who proned less than 5 hours, there was still a significant reduction in endotracheal intubation. We also did a subgroup analysis trying to identify patients who may benefit the most from awake prone positioning. And similar to what we found in the first subgroup analysis, there was not a differential effect between the both subgroups. Recently, an interesting study was published from China, where they recruited patients with COVID-19, but they randomized them into 12 hours a day minimum of proning versus proning usual care. And surprisingly, they managed to achieve the target of proning in all days of randomization of 12 hours, which is amazing. We had extreme difficulties in getting patients. I think the patients who proned for 12 hours were very, very few in our trial. So we'll have to ask them what magical intervention they have used to achieve this. But the results are very interesting, and it supports our observations. Again, this is the hazard ratio for endotracheal intubation. Similarly, they had significant reduction in endotracheal intubation, and they found for the first time a significant reduction in risk of death if you prone patients for a long time. Again, single study from single country, but it may give us an idea, or at least confirm our observed effect in intubated patients with longer in prone positioning is associated with better outcomes. So what do the guidelines say? I was involved in this guideline as a content expert, but because of my conflict of interest as the PI of the study, I was not allowed to vote, so I had no influence on this recommendation. But I believe in this guideline, it was the first that strongly recommended using awake, or offering, let's say. So the recommendation states the following. In non-intubated patients with COVID-19 and acute hypoxemic respiratory failure, we recommend a trial of awake proning. So the recommendation is to offer patients proning, but it's really up to them to stay in prone position or not. And it was a strong recommendation based on moderate quality evidence. Also, the NICE guidelines, although they don't specify the strength or the quality of evidence, They also advocate for considering awake prone positioning, and I see that this has translated to practice very nicely, as many people here in this room, almost everybody, have prone patients with COVID-19. So, as I showed you in the research program, we plan to conduct an individual patient data meta-analysis, which was just accepted in a medical journal. I hate it when I'm not allowed to present the results, but to make it worthwhile for you guys, you're here very late during the day. I may hint towards some of the results, but I can't show you the actual results, but hopefully, I would say within the next few weeks, it will be out in press. One of the things that we learned, I can't deny or confirm if it was from the individual patient data meta-analysis, but that predictors for better outcomes included those who are younger than 65 years of age, those with a BMI between 26 and 30, it's not grams, it's kilograms per square meter. And if you prone patients early, within an hour or two of admission to the ICU, those with a PF ratio, as we have seen in our trial as well, above 150. Those who are receiving advanced respiratory support, i.e. high flow nasal cannula, but also patients who prone for more than 10 hours were likely to benefit more than those who did not. So this takes us, I think future studies should focus on approaches to enhance compliance. How can we make it easier for our patients to stay while awake in this very uncomfortable position? I have to admit, I sleep in prone position since I was a baby, so it's not a problem for me. However, for our patients, it's not the same story. So multiple interventions are being tested. There are qualitative studies that looked at education and encouragement of patients, but again, very small. Perhaps some supportive devices to support pressure areas during awake prone positioning would be helpful. I also learned something, that there is now sublingual dexmedetomidine. I have to admit, I've used dexmedetomidine infusions in some patients who are awake and prone, but again, these are anecdotes. So maybe future studies focusing on managing anxiety, pain, and hopefully now without the fear of getting COVID, nurses and respiratory therapists, physicians, everybody can get into the room, encourage patients, and maybe achieve higher compliance rate. But it's really the major theme across most of the trials is ambitiously targeting higher hours of, or longer hours of proning, but not able to be sustained. So now back to the question of this talk, and again, it's a very challenging question. Should we use awake proning for patients with acute hypoxemic respiratory failure without COVID? And I don't know the answer. I can tell you what I think, but I'd like to ask you guys, how many think that we don't need randomized trials in non-COVID patients? Oh, a couple of people. How many think we absolutely need trials in non-COVID patients? Okay, so more people are in favor of an evidence-based approach, and some or very few are in favor of using indirect evidence to help inform practice. Again, we know that COVID had a unique pathophysiology that may be a little bit different than other illnesses or patients who are coming with pneumonia or being admitted to the hospital. But those with viral pneumonias may benefit, but somebody with cardiogenic pulmonary edema, COPD, or hypoxemic, or other kind of patients with hypoxemia, I'm not sure if it's the right thing to do. I found this study, which was published from China. They looked at non-COVID patients, I think 9 or 10 patients who presented with acute hypoxemic respiratory failure. And they measured the physiologic changes. They used EIT, and as you can see, this is when the patient is supine. When they're in prone positioning, there is more or better ventilation in the lungs. That's not sustained when they turned back on their backs, and was consistent across all very small cohort of patients. But also they looked at other physiological markers, and they found better oxygenation, maybe not much effect on respiratory rate, but the effect was not really sustained in patients when they turn on their backs. So again, this was probably the only physiological evidence. I'm almost done. Physiological evidence in non-COVID patients. And this is the last slide of the day, just to summarize what we have discussed. So we know awake prone positioning reduces the risk of intubation, but in COVID-19 patients. I said probably reduces risk of death. Maybe when you read our paper, this will change a little bit. There's a huge compliance problem that we all need to work on, and probably do more studies to enhance compliance to awake proning. Try as much as possible to target longer duration of proning. Although in our trial we found 5 hours to be effective. As it turns out, longer than 8 hours is also better than 5 hours. Prone early if you can, and we're hoping that future studies will help focus on compliance issues and helping those patients to stay on track. Thank you.
Thank you very much, Dr. Hazzani. Maybe I'd invite all the speakers up to the stage so we'll take some questions. Really a bunch of very interesting talks, so thank you very much, gentlemen. Really a pleasure to listen to all of them. So I think it's, we have time for questions. I know I have a lot of questions here. But we'll start maybe with the audience, if anybody has any questions. Sarah?
Hi, thank you again for all the nice presentation. My question for Thomas. I know you spoke about the SFG balloon and the pressure. I'm wondering, have it been tried on pregnant women? Because every now and then we get a pregnant lady who, with H1N1, influenza A, who got intubated. And again, we know that the compliance is different with the gravid uterus. So is there any application for the SFG balloon for this subset of patients?
I personally feel that there is. Unfortunately, as you know, pregnant women are mostly excluded from clinical trials, so I don't know the answer. I don't want to be the one to say we should do it. I feel like there's a role, even if it's just to understand the complications, whether or not we target PEEP, et cetera, but I think it's useful. I believe I know I've put it in one pregnant woman. I feel like it's been 2, but I don't even want to share my anecdotal experience, but it does provide some useful information. And the PEEP targeting in these patients, if you had a patient who was pregnant but also has the condition of obesity, this, again, likely would be a very beneficial thing to utilize, but I mean, we don't have evidence of that because of the exclusion in all the trials. We really do need trials specifically in this population, but it would be very challenging because, to be perfectly honest, I don't see a whole lot of pregnant women in the critical care ICU. And usually when I see them, it's post-delivery.
That's a big issue of RCTs in critical care, that pregnant women or also patients who have a difficult background of homelessness or drug abuse are systematically underrepresented in these studies. And emulating target trial, benchmarking them against available RCTs might represent an opportunity to extrapolate the evidence from RCTs to these most vulnerable patient population.
Thank you, Marta. I mean, actually, on that subject of RCTs, I mean, we always have a debate about, driving pressure, and wonderful data about driving pressure that you presented and you guys published. But, to me, do you think we'll ever see randomized studies looking at, because there have been attempts in the past, published attempts?
Thank you for that question. So, the important thing is the well-defined intervention in the sense of how do you actually influence driving pressure? Is it just limiting tidal volumes? Should you titrate PEEP to modify driving pressure? Should we what is the influence of respiratory rate? Should we sedation strategies? Should we put all the patients on ECMO in order to limit driving pressure? So I think, or prone positioning can influence respiratory mechanics, very important. So I think the key to get a decent trial with answering the causal question is to define the intervention very well. And I know that within the practical platform, we are currently running a trial that investigates whether driving pressure should be limited. So we are actively trying to figure that out.
Just one more comment to add to that. I think the smart and intelligent thing with the practical trial is that they are also stratifying patients for those with stiff lungs, so those with high respiratory system elastance and those with low respiratory system elastance, because as continued data begins to be published, and we already have some data, you have to look if the baseline driving pressure in these patients is low, like if the average is 13 centimeters of water, we don't really know if the intervention they don't have to do anything to intervene because the pressure is already low. It doesn't answer the question. So stratifying patients, we may learn that maybe reducing driving pressure is beneficial in patients with stiff lungs, and it may not be in those with healthier lungs.
We have time for an additional question from the audience.
Thank you very much. The question to Lorenzo. Regarding the criteria for high-flow nasal cannula and converting over the time to decide to convert into invasive. I think for a general practitioner, we want something like really easy to approach, maybe multiple criteria. I noticed that you quoted, for example, the pH. Was there anything in the criteria, was there anything in the literature telling us about taking the lactate into perspective, since the lactate probably precedes the drop in the pH. You're going to have, provided that the patient is hemodynamically stable, the lactate will be prior to the drop of the pH because you're going to compensate first. And then when you have the pH dropping, that's probably too late. So anything about the lactate?
Yeah, so very, very good question. So I completely agree, first of all, that the easier is the recording of the variable that will guide our treatment, the better is the application and the implementation on a clinical side. Lactate has been measured in the paper that they, both in the training phase and the validation phase of the paper, studying the ROX index, and there was, the signal was the sensitivity specificity was very low. Okay, but you're completely right. This may be due to the fact that lactate, when the patient workup breathing is very high and so is heading toward intubation, the modification of lactate maybe is a late event, okay, preceded by the others. Okay, so unfortunately we need to live with some uncertainty still on that regard.
Thank you. Since I have the mic, I have a question for you, Walid. It's very, mashallah, very nutritious session, all of you guys. Regarding the application of the prone positioning for the awake, especially with the criteria that was put, I mean, like I'm sure you faced that challenge. Like 5 liters, that must be, a patient is actually not under your eyes in the ICU. This patient is actually in the ward. Because at that level, so can you see now the difference when you are the one with your own rapid response team, when you are the one who's giving the directions to follow that patient and make sure that he's doing A, B, and C and applying all the criteria versus a hospital that doesn't have rapid response team where you're indoctrinating others to say, please prone your patients in that criteria. So I'm trying to say that probably one of the things that we would have considered whether there is actually a direct implementation of the the proning package versus it's been recommended for other units but probably applied or not, and that's why influenced the compliance. I don't know what's your take on that.
Yeah, great question. But also, if you noticed in our inclusion criteria, we included only patients who were in the ICU or in a monitored setting. So this is why we ended up with a median of 70% oxygen requirement, sicker population. But I agree with you, and hopefully we don't see another pandemic, because I think the main concern was the pandemic, and these patients can deteriorate quickly. They need to be in a monitored setting. We had also concerns at that time whether awake proning may delay things and people will get even sicker and get intubated. But as it turns out, earlier is better. And for those who are really, really sick, you could offer a trial of intubation, but as the data showed, most of them will probably end up being intubated. So it's a judgment call.
I have a question for, or should I move there? No. So I'm puzzled about some of the results of the trial and maybe also the hypothesis of it. So in the multiple randomized controlled trial in patient mechanically ventilated, okay, not your patient population, but they were already ventilated. There were some data showing that the proning is beneficial in patients with lower PF ratio, okay? Whereas there's no effect whatsoever for patients with mild ARDS. Instead, so I was already questioning why then we should prone patients that are not even intubated, but I may understand that the severity is the same. But I don't understand, or can you elaborate a little bit more why your signal is the opposite? So you have better effect, if you want, in milder patient than more severe patient.
Great question. I think the answer is convoluted. It goes back to the decision to intubate the patient. Decision to intubate could be related to hypoxemia. So we know that prone positioning improves oxygenation that make the patient look better, maybe buy you some time early on and for the medications to start working. We have specific therapies for COVID-19. But for those who are really, really sick, it's probably just they need positive pressure, they need to be intubated. So I think maybe that's partially will explain the results, but I agree with you. We're also, and to be completely transparent, our hypothesis when we did the subgroup analysis was exactly as you mentioned. We were like sicker patients probably will benefit more than less sick patients.
All right, thank you very much. For the sake of time, I mean, there's so many burning questions, but for the sake of time, thank you very much, gentlemen. We really appreciate the talks, and thank you very much, everybody. And hopefully you enjoyed the talks as much as I did. So have a good afternoon. Thank you.